Good evening, everyone, and might be good morning, good afternoon, somewhere else. So we'll start this session. So I'm Dr. Sushil Jain. I'm the honorary advisor for GAPIO. I recently took over from Dr. Tandon. I'm medical superintendent at Apollo Hospital, Indore. I was part of the cardiac surgery team till for about 14 years, and since 2019, I have taken over the administrative part as well. About GAPIO, so GAPIO is a non-profit organization which was established in 2011 by Dr. Pratap C. Reddy as the founder president, along with Dr. Sanku Rao and Dr. Ramesh Mehta. It was established with the aim to bring the around 1.4 million physicians of Indian origin together to one platform. Currently, GAPIO has presence in around 57 countries with members spread across the various specialties, super specialties, and subspecialties. So this session we bring out, this is the first nephrology session for this year. And this is in collaboration with the Avatar Foundation, which is led by Dr. Sanjeev Jasuja. I welcome him and Dr. Gaurav and Dr. Mragang as the chairpersons. Dr. Gaurav Sagar is working as a consultant nephrologist at Apollo Indraprasth in Delhi. He has 10 years of experience in renal medicine with special interest in vascular access, high-risk kidney transplants, and critical care in nephrology. He has been pioneer in practicing and promoting interventional nephrology in the North India, and was part of the team which conducted the first ABO incompatible transplant in North India. Dr. Gaurav has 10 abstracts on vascular access submitted in last 2 annual conferences of Indian Society of Nephrology. And Dr. Gaurav has set up the first PPP standalone dialysis unit in 2009. As far as Dr. Mragang is concerned, he is BN Nephrology from PGI Chandigarh. And currently he is associate consultant in Epitome Kidney and Urology Institute in Lions Hospital, New Delhi, and assistant consultant in nephrology at Indraprasth Hospital, New Delhi. So with this introduction to our chairpersons, I'll invite Dr. Gaurav Sagar to introduce the speaker, Dr. Sanjeev Jasuja, and take this forward. Thank you.
Thank you, Dr. Jain. Thank you, Dr. Jain, for this invite. It's a privilege and honor to be here. And a bigger privilege for me to introduce is Dr. Sanjeev Jasuja, who has been my mentor and who is an excellent physician. And I must say that in his guidance, we did the first ABO incompatible transplant in 2011. So at our center, in the last 10 years, we have been specializing in doing high-risk transplant. Kidney transplant definitely improves the quality of life, and it is the best renal replacement therapy you can offer to a patient. And transplant immunology also has advanced over the last 10 to 15 years, and it has been possible actually to do high-risk transplants, which were being rejected initially by so many physicians. Dr. Jasuja has been my mentor, and he is currently serving as senior consultant and academic coordinator for the Department of Nephrology at Indraprasth Apollo Hospital. He has a vast experience of about 25 to 30 years in interventional nephrology, clinical nephrology, and he's also a master in critical care nephrology. He is also the National Board Teacher for Super Specialty Training. He is Professor of Medicine of Apollo Hospital Educational and Research Foundation as well. He has about 40 publications, which also includes many chapters in very important books as well. He has medical experience of about 25 years with special interest in kidney transplant, especially the high-risk transplant. And under his guidance, the first ABO incompatible transplant was done in North India. I remember his out of the box thinking was so crucial for this. And he realized that when we can do high-risk transplant, why can't we do an ABO incompatible transplant? And this thinking actually paved way for so many ABO incompatible transplant in future. He's also the founder member of Avatar Foundation, And Avatar is a platform to showcase intervention nephrology. And under his guidance, Avatar has been taken to an international level. And it actually, Avatar every year conducts a national conference also. And that is actually the most attended in the country nowadays. With this introduction, I would request Dr. Jasuja to kindly start his broadcast.
Thank you, Dr. Sagar. Thank you. It's been a pleasure to be attending a program which is being chaired by Dr. Sagar and Dr. Mrigant. Dr. Sushil, I'm grateful to gap you with this opportunity. Am I audible to everybody and clear? Okay.
Yes.
I've been given the responsibility to talk about what exactly how the transplant has evolved around us, particularly in an organization like Apollo, more so in Apollo Delhi. So I would just take you through the journey. Now, as we move, before we understand any problem, yeah, this is an important slide. When we talk about something, we need to have a complete insight about what is the quantum of problem which we are going to deal with, and what, unless we know about that, unless we have the hang of epidemiology of a particular disease disorder, I think it's futile to talk about the interventions or the procedures or whatever we are going to carry out further. The irony of the third world, like country like India, is that we do not maintain any kind of a registry. So to figure out what is the quantum of the kidney disease around us is very, very difficult. But then there are some lateral ways to look at this problem. If you look at some of the publications, particularly which is, if you look at where I'm showing my arrow, this is in a publication which has come from UK, where they had looked in from Indo-Asian population, which includes, of course, Indian, Pakistan. I would say the Southeast Asian, most of the Southeast Asian countries' population has been listed under this. And here, if you look at this particular red square which I'm showing, now the incidence of CKD is around to the tune of about 200 patients, or maybe 220 patients per million population. And similarly, this is the data which has come from USRDS. According to this, though of course this is not very exclusively for Southeast Asia, this includes other Asia Pacific islanders, which includes Indian people also. So where the incidence is decade by with every passing year, it's increasing, and the latest has been reported, though of course it's an old data, but it's showing about 400 patients per million population. This is the incidence which has been judged by Global Kidney Disease Initiative. According to this data, if you look at this number, this is showing roughly to the tune of about 200 patients per million population. And we are roughly now 1,400 million population, we can say, on an average in a year's time. We get around roughly about 4 to 5 lakh patients who are seeking some kind of a treatment strategy. Now, in the same data, if you look at this part here, the India is squeezed somewhere here. Although it's a small slide, it will not be able, you will not be appreciated, but India is somewhere around here. Now, this is showing the prevalence of end-stage kidney disease in India. It's rare to see a disease which has an incidence of 200 million per million population, has an incidence or has a prevalence of only 50. But it's possible. I mean, if you look at if you're not able to sustain your patients across a calendar year, and that's the factual irony of our, since we are not able to sustain them, the prevalence is even lesser than incidence. So that means our patients die in few months. That's the ironical fact which we have regarding the chronic kidney disease, probably in our patient, and that's been very recently published data from the Rajiv Gandhi Arogya Nidhi, where they have seen that in 6 months' time, about half the patients stop coming to the dialysis center. Either they are not there, or they find it difficult despite the fact that the dialysis is being offered to them almost at a free of cost. So this, and then there is a data which has come from the Sikh study, where even I was a part to it. According to this study, the prevalence of chronic kidney disease population. And if you look at by 800 per million, so we have probably at a point of time in India, roughly about 12,000. We should have about 12 lakh patients as a piled up patient, but that's not the number. If we can sustain only to incident patients, I mean, we would be probably doing a great service to our nation. And this, the last corner which I'm showing, this is the data which has come from, which is Dr. S.K. Agarwal from All India Institute, professor and head. He did this study. Again, the numbers are almost similar. Now, if you look at the cumulative numbers on this side, the incidence probably, this is a guesstimate, this is probably the educated guesstimate I can say, of chronic kidney disease is about 250 patients, and prevalence varies anything between 50 to 800. Sporadically, it should be 800, but actual sustained patients may not be more than 50 per million population who are carried on to the next year. Now, with this backdrop, this is the reality now. If you have a 250 patients per million population, we are doing on an average about 6 transplants per million population. We are doing about 4 CAPD catheter insertions in a year per million population, and about 20 patients are initiating dialysis. Of course, this number has changed. It's 20, maybe now, maybe 40, because in last 1 decade, the government has really pitched in a very big help, in the sense that we have set up the dialysis centers at every district headquarter. But still, as I said, the studies are showing that despite the free dialysis availability to the population which is below poverty line, the patients are not able to turn up beyond a particular certain point of time, maybe because of the financial logistics. Now, as a result, if you do the total of this number, this comes out to be 30 and 220. Out of 250, 30 patients are able to get some kind of a treatment. What happens to this 220 patients? I mean, that's the fact. And these patients are they're unable to continue treatment. They die, and that's the reality around us now. Now, when such is the reality, how we can what is the solution? Probably there's nothing better than a prevention. But prevention, to take it down to percolate a preventive strategies to a common man, it's a mammoth job. It's not possible. Other option is that we build the capacity building part. Now, of course, as I said, in last 1 decade, the capacity building towards dialysis definitely has taken a big leap. The government of India is doing a big job, and every year, every state plus districts plus the central government, all are taking different kind of initiatives, and a lot of PPP models are coming up, and there is more and more dialysis setups are being brought for the public. But still, let's see how far that would change. Unless the quality delivery is there and the patients are able to come to the center and take the service, the outcome may not change much. Other important factors capacity building is that we should increase the number of transplants which we are doing in the country. And why we should favor transplant vis-a-vis hemodialysis, some data. If you see the annual mortality rates, the patients who are undergoing a dialysis, mortality rate is to the tune of about 21 to 25%. That means every fourth patient at the end of 1 year is not continuing because of the mortality. On the contrary, if you look at the annual mortality rate of cadaver transplant is less than 8%, and living related transplant, which is most prevalent in our country, is less than 4%. So if you see the comparison between the mortalities of the dialysis and the mortality of the patient who get a transplant is phenomenally different. So the survival chances are 5 times higher if one gets a chance to get a transplant as compared to patient who is left to carry on only on his life for the dialysis. And another important question, which I'm sure somebody is going to think about it, if we're offering a transplant, does it do the same good job for the younger people? Does it similar job for the diabetics? I mean, this is a query in everybody's mind. Are the diabetics? If you look at the data below, if the years of life for a patient is between 20 to 39, if the patient is non-diabetic, if he's on dialysis, probably he might get about 20 years. On the contrary, if the patient gets a transplant, he would probably get 31 years. And there's a bit of a data which I'm not able to see because of the bar in my area. But actually, it shows if you can see that under your bar, is it covering everybody's screen, or it's just my screen only? So if you look at the diabetic patients, which is at the bottom of this, the patients can survive on dialysis, diabetic survival on dialysis about 8 years as compared to as against more than 2 decades if the diabetic patient gets a transplant opportunity. So probably the chance of living is far higher in diabetics as compared to the patient higher the comorbidities, the best is the outcome of a transplant, provided the comorbidity is not impinging upon the surgical procedural scope. I mean, if you're doing a surgery on a patient who has a very riskier heart disease, the patient may not survive. But otherwise, most of the patients, whether they have a cardiac disease or a diabetics, they do far better if they get a chance to get a transplant as compared to if they are left on dialysis. So that's why the dialysis is one of the important. Now, how we can percolate the dialysis? For that, either we have to improve the financial status of individual, which is beyond our capacity. But important things which we can do is strengthen a cadaver program, which again I would put it in last about 2 decades. There is a serious change ever since we have acquired this quota as an act. In our country, the cadaver transplant program under the NOTO, SOTO, I mean, it has become up almost a reality, and the cadaver distribution has started from the NOTO nodal centers. So that, though it's happening if you look at the northern part of the country, it's happening in a very minuscule way. But yes, it's taking shape. But I'm quite sure in our lifetime only we'll see almost a proper, regular happening cadaver transplant program in the entire country, the way the whole system has been set up in across the length and breadth of the country. Now, other important thing which we, as a clinician who are currently practicing in a hospital which has all kind of facilities around us, is that we can change the criteria, we can have the inclusion criteria, we can improve the inclusion criteria. That's what Dr. Gaurav just mentioned when we were making our unit introduction. So he stated that we set up the cadaver transplant, apart from the high risk transplant, we are doing ABN compatible in a big way. So the reason to set up this was so that we should not deny the privilege to the patients who can have a donor, even if the blood group is not matching, so that we can give them ABN compatible transplant. So all the criteria, apart from ABN compatible, whichever is the reason that we are not able to give a transplant, we should try to include those patients so that the benefit of transplant should be passed on to each and every possible individual person who is suffering from chronic kidney disease. Now, if you look at any of the textbook, if you open any of the textbook of olden times or even the recent times, this is a list of about 14 diseases which are considered to be the exclusion criteria for anybody to be considered for a transplant. The ABN compatible, HLA type, and there's so many of these. So what we have done at our center in the last 2 decades, we have almost circumvented most of these contraindications and
is everyone able to hear Dr. Jasuja? There was some interruption in the connection, I think.
Yeah, which is saying that my connection is unstable.
What we can do is we can switch off the videos if the connection is unstable.
Is it okay now? Is it fine? Is it okay now? Am I audible?
Yes, sir, you are.
Okay. So once we add patients with across the blood group, I mean, if we start giving ABN compatible transplants, what has been realized that at least majority of the families, at least 25% of the additional patients can be recruited for the transplant. Provided they have an understanding what are they going through. There are some systematic scientific way of conducting this procedure. The cost involved is slightly more than the conventional transplant. And fortunately, at a place where we are working, generally the financial constraints is not a major hindrance in our performance. So because of that, the number which I'm showing is 9 years, but it's more than 9 years we've been doing it. We have already done about more than 500 ABN compatible transplant in last 1 decade. And we analyzed that outcome also, and the outcome was nowhere different than what we have with the compatible transplants, almost a similar outcome and groups. Yeah, the second important contraindication for transplant had always been that the patients who are having the anti-HLA antibodies, they're called sensitized recipients. Anybody who's sensitized recipient had been earlier days was asked to either wait for a longer period of time, or they were not offered the transplant because of the risk of high rejection. But over the years, there are techniques and technology has evolved to a level that we can take these patients also, provided they have a available donor. We can desensitize these patients, and this desensitization process, of course, has to this patient has to run through system which includes rituximab, plasma exchanges, relatively a more robust kind of induction protocol, and then of course a profound maintenance and a very diligent kind of a follow-up is required for desensitized patients. And most of these patients, when they are executed in a proper formal order, with taking into account antibody levels and repeatedly monitoring them, DSAs, and fortunately we have a wonderful backup laboratory with us, which provides us all kind of support in testing and following up these patients. So we are doing a desensitization. We are running a desensitization protocol in such situations and giving transplant to our such patients. And in fact, we have at least two patients where we have ABO incompatibility plus a sensitization also in a patient. So we have because the protocol is similar. So we have done transplants where the patient had antibodies against the donor, as well as the blood groups are not matching. So these are the rare achievements that these kind of transplants are generally not done across. Unless the center is very robust, very few centers have attempted these kind of transplants, which we have fortunately been able to carry out and successfully. Now, then there is a very unique experience. If anybody who is listening to this talk and has an experience of a transplant, a couple of years back till now, it was a rather very standard practice that even despite a negative cross match, when you do a transplant once in a year in a relatively more frequent programs, it was seen that despite negative cross match, all kind of testing, even flow cross match is negative, and once you declamp the kidneys after putting it in a transplant, the kidneys would turn blue. Some kind of antibody level, which preformed antibodies were in circulation, which could not be tested by a conventional test. So we had to, and the practice was that most of the time the surgeons would disconnect this kidney and put it in the dustbin, so that this transplant used to fail while in OT itself. And that was one of the most dismal thing which as a clinician we would like to experience in a given day when we are with so much of hope a transplant is performed. And in last couple of years we had 5 such occasions now, the few transplants which we have done, where the kidney, while releasing the clamps, turned blue, despite the fact, if you look at this CDC crossmatch were negative. There's one patient who had a DSA positivity, and we had run a proper desensitization protocol, and this patient achieved a particular targeted MFI levels and then transplanted, but still the kidney turned blue. In all these 4 patients, we did something which is yet not been reported. We wheeled in our paraphernalia of desensitization into the OT itself. Now, this is if you see, this is a plasma exchange equipment which is lying next to the boils apparatus. So what we did, we started doing a plasma exchange with high dose IVIG to these patients, and to the tune of about 500 milligram per kg, and that was given over 6 to 8 hours in operation theater itself. And then we removed the kidneys, reperfused these kidneys, and kept them in a cold till the procedure was carried out, and reattempted the transplant. And fortunately, we were successful in all these 4 patients, and we could retransplant them instead of throwing these kidneys into the dustbin. And this is the protocol which we ran in these patients, and see, out of 4, we could save 3 kidneys, and the creatinine at 1 year follow-up was, these are the numbers which are almost like any good transplant. So the failing kidneys have been probably, which we could salvage these kidneys also. Another important, that if somebody's got a recent malignancy, although of course one has been cured. Mostly the time tenure or the cancer-free time, which is uh, recommended, is about 2 years in patients who have been treated, have completed their anti-malignancy or anti-cancer treatment, and they are waiting for a kidney transplant also. But with the advent of the PET scan, we have reduced this time tenure to about 12 months in majority of our patients, and we have done about 5 such patients in the last about 4.5 years, where the patient had some kind of malignancy which was treated more than 12 months back, and since the 12 months intervening period, which on multiple occasions through PET scan had shown that there's no further recurrence or metastatic lesion has appeared in these patients. We have transplanted them, and we have followed these patients more than 12 months, and we have not seen any recurrence in these patients. And on a repeatedly basis, we are doing a PET scan in these patients whenever they come for annual follow-up planned. Otherwise, they are doing their regular follow-ups as other kidney transplant patients. Now, any active infection is there no, but now we have most of the chronic disease infections are treated pretty well, and in TB also we are giving transplants in after about 6 weeks of adequate anti-tubercular treatment to this patient. At one point of time, the retroviral disease was considered almost a complete no rather for transplantation, but now there are protocols which has been set. Once the patients are on ART and their CD counts are for at least for 6 months more than 200, you can consider them for a transplant. Except for that, you can't use PIs, because PIs have interaction with the transplant drug. Apart from this hindrance, we are transplanting these patients as anybody else. We have done close to about 40 transplants of retroviral in last almost decades time, and most of these patients are stable and doing fine as other transplant patients. Now, there are patients who come with the advanced cardiac disease, pulmonary diseases, and hepatic dysfunction. So where the other organ terminal dysfunction is there, so we can consider them for a combined transplants also. And as far as the cardiac is concerned, we have done about 255 patients where we have done revascularization in terms of CABG or stenting, and 18 patients of valve replacement. Now, the valve replacement, I must put it, is one of the difficult transplant surgeries, because most of these patients are on anticoagulant. But theoretically, most of these anticoagulants are stopped well in advance and put on the low molecular weight heparin, and then we go for a transplant. But still, these patients do give us a difficult time post-transplant with in the graft fossa hematoma formation is not uncommon. But anyway, we know how to handle these patients, and we've been able to get over all these, and all these patients have been successfully transplanted. Now, as far as the pulmonary disorders are concerned, except for somebody who's got a fungal cavitary lesion, and we cannot take out en bloc lesion surgically, except for such patients, most of the pulmonary disorders, we have been able to transplant these patients. And on hepatic advanced disease, we are doing the combined kidney liver transplant. In fact, I have been very fortunate that this program has in the country simultaneous kidney transplants started in 1998. For the first transplant patient was done at Apollo New Delhi in India, and I was his treating nephrologist. And very difficult situation where in fact, we did not have the knowledge about how to carry out, but the patient did very well with that. We had a very dedicated team which worked around for both the kidney and liver transplant happened, and we got a cadaver. And of course, this was offered to international patient, not an Indian to start with. But this is a reality now. And in the last 2 decades, we have done about 45 simultaneous liver and kidney transplants, and their outcomes are as good as either kidney or a liver transplant in individual capacity. I'm sorry for this little muddy slide. I'll just move on. Now, actually, in this slide, I'm trying to show this particular segment. If you ignore the upper part, there are some patients, there are some reasons not to do transplant in patients where you feel they have some psychiatric disorder. With the current armamentarium of antipsychotic drugs, most of these patients can be turned well compliant, and we can give them a transplantation. And for morbid obesity, we are developing a program of robotic transplant, and I'm sure this is going to be reality in next few few weeks to months at our place also. And there are a couple of centers in India has taken lead above us. They are doing these kind of a transplant with the help of robotic transplantation. Now, another important contraindication which has been listed in the transplant is the age of the patient. The patient is having an age more than 70 years. It's stated that the outcome of transplant may not be different than being on dialysis for at least for first 2 years. But if you look at, though of course we are a younger nation, if you look at our 5% of our population, whether male, female, either way, if you look at this number, is more than 65. So you deny the privilege of transplant advantages to this particular population, which creates a big segment. And if you see after first 2 years, the transplant definitely scores better as compared to the patients who are on a waitlisted for dialysis, or even as a matter of fact on dialysis also. So if you transplant these patients for initial 2 years, there's always, apart from these 2 years of bit of hiccups, if the patient has survived this period, then the survival are far better as compared to the dialysis patient. Now, there are two things, particularly after the age of 70, we have to really take two facts in account. One is their cardiac status, if that permits, and then the lower urinary tract prostatic issue. If there's no major prostatic obstruction and the patient has a continent system, plus his coronaries are not going to give us a problem with transplant such patients very successfully. And in fact, if you look at this number, we have exceeded more than 70, about 100 transplants. We have done more than 65. Roughly, this number is a little old. I would say more than about 350 by now. And the oldest patient whom we have transplanted at is 78 years of age. This guy was asked when we transplant. I was asking why you're so keen to have a transplant. His daughter, she was 50 years, she had come as a donor. He said, once I get a transplant, I'll go and get married. So that was his intent. So I had no reason to deny him the transplant if he had so much of to go on. Now, other important diseases is like primary hyperoxalosis. Then there are certain other in primary oxalosis. Most of the patients will they have either the stone formation or because of the hyperoxaluria, there's a interstitial renal dysfunction, and they have an end stage. In such patients, we offer them the combined kidney liver transplant, and we have reasonable good experience of such kind of a transplants as well. So this had been a contraindication primary oxalosis a couple of years back, but no more now. With the advent of simultaneous kidney liver transplant, we have been able to salvage these patients as well. Now the persistent coagulant disorders, which at one point of time were thought not to be transplanted because of the continued bleeding, but now since we have the availability of recombinant factors, most of these situations we are able to circumvent, and we can give them a transplant. I think with this, I would like to give it a pause. If there are any questions, I'm very happy to take.
Good evening, sir. It's actually just one question I have posted. While you were talking about those people who have had a malignancy in the recent past and which was taken care of, and ideally you should wait for 2 to 5 years, but like we have documented, you told in the PET that malignancy was gone, and we went with the transplant. I was interested in knowing what kind of maintenance immunosuppression protocol did we use was like sirolimus included in mTOR inhibitors was a part of their regimen, or how did we go about it?
Yeah, Mridang, this is a very good question on you. Am I audible? No? Everybody can hear me? Am I audible? Okay. Now, most of our we have not done lymphoma kind of a transplantation. I'm talking about the solid organ transplants when the 12-month solid organ has been found, the patient has been found free from solid organ metastatic disease or the primary recurrence. That these are the patients, and we have not given rapamycin in this particular population. We have given them a conventional standard, except we have avoided induction protocol. That's the only difference I would say. But we have transplanted them with a conventional 3-drug regime, which includes steroids, tacrolimus, and
Thank you, sir.
Sir, if you permit, can I ask a question which is not really related to kidney transplant, but more sort of technical thing? So in case you must be associated with a lot of
Right,
cadaveric
sure.
organ donation. So in cadaveric organ donation, what is the order of harvesting the organs?
You mean to say which organ is to be harvested first of all?
Yeah. So what is the usual chronology of harvesting the organs?
See, most important organ which is to be immediately harvested is the cardiac, and most of other organs have reasonable the shelf life which once they are transported. In fact, for now the cardiac also there are some special solutions available. So there was a time when the first harvest would go to the cardiac harvesting, and there was a separate run for these. The cardiac transportations were carried out with the fact that there wouldn't be much time around it. But with the newer solutions, even for the cardiac also, we can retain the cardiac activity for 24 hours, and the cardiac organs are also kept for more than 24 hours and can be transported from one city to other city. Now the harvesting goes like cardiac, liver, kidneys, and then of course pancreas, and then comes the organs like cornea and other things could be carried out.
Thank you, sir. Thank you. Over to you, Dr. Mayank and Dr. Gaurav.
Thank you, sir, for the excellent talk. I'll now invite Dr. Gaur to give the termination. Closing remarks, please.
Thank you, sir, for the wonderful presentation and sharing with us the incredible work that the hospital has been doing, especially the SLKT success and the one where you use Plex in OT to salvage the kidneys which were having hyperacute rejection. Those were something new, which is like in training, we didn't see much of a success with hyperacute rejection or simultaneous liver and kidney transplants. And also good to know that we have a reasonable number of these elderly patients who we have been successfully able to transplant here since the program is running. And the other interesting point was when you took the challenge of ABO incompatible plus the desensitization, because as you rightly pointed out that the medications used in the regimen is more or less the same to get rid of the antibodies, whether they are pre-existing or which the person forms because of some sensitizing event. So those were the highlights for me of this presentation. Thank you for sharing the words, sir.
Thank you, Dr. Megant. But I must say that there are two things which really matters to you. It's a platform where you are working for, and the people with whom you are working along. I mean, I've been very lucky to have Dr. Gaurav Sagar had been part of our team, and there are other colleagues, Dr. Anupam is here. So we would always discuss and share and enhance each other's knowledge to a level so that we could do anything, whatever and whenever we wanted. So we for last more than a decade we've been working like one team, and we have definitely done some great work as well, and some of them is a very exceptional work, in fact.
Yes, sir.
So I'll request Dr. Magang to give the final comments and the vote of thanks. So thank you, Professor Jasuja, sir, for sharing this presentation with us and whatever work the hospital has done, good work that we have done for our community, and also highlighting the areas that need to be further improved upon, like whatever we can do to enhance, to ensure that most of our patients who we come across, although like referral is always late for the nephrology community, but we should salvage most of our patients and ensure that they get a better quality of life once they come in contact with us as a nephrologist. This should be our aim. And I will also thank Dr. Sushil and Dr. Gaurav Sagar, sir, for giving me this opportunity to be a part of this whole experience. And hope we can have more such meetings in the future and continue to share our experience with each other.
Thank you so much, everybody.
Thank you. Thank you, sir. Thank you, Dr. Magan. Thank you, Dr. Rao.
Everybody, have a
Thank
good
you.
time.